I am Sara Ramirez. I am Associate Professor of Family and Community Medicine, as well as Family Medicine Obstetrics. I'm going to multitask here, so apologize for my eyes going everywhere. I'm currently on labor and delivery on call in our beautiful call room, which you can't see. I'm strategically hiding with my background because it's beautiful, being sarcastic. Um, but I wear a few hats here. I've named a few, but we are very excited about today's meeting, and thank you everyone for joining. I hope that everyone has come with their discussion hats on and is ready for a very engaging and dynamic conversation. So for today's agenda, I'll start us off with a brief welcome, introduce you to the founding team, give you a little bit of background, and give you a quick overview of our general priorities. David Saunders and Kensei will get deeper into that later on. And then we'll briefly touch on the goals for today's meeting. We're also going to talk about some success and action examples for you, describe an exciting, wonderful project, Implicit, and also Philly Joy Bank. So 2 examples of maternal health successes in Pennsylvania. We're gonna, what is a Zoom meeting without breakout rooms? So we're gonna do a couple of breakout group discussion, and then we're gonna talk about next steps and adjournment, and where do we go from here. So the first thing, I just wanna give you an overview of who is the team and also talk about how was this born. So this was born out of a conversation that David and I had early this year. Largely driven by our common frustration with our outcomes and why can we not move the needle forward in lowering maternal health mortality or maternal mortality. When we look at the data, we all know the data is awful. And yet I'm sure, and we were sure at the time, that there were people around Pennsylvania working on these initiatives in silos. And what we wanted to do is really form this collaborative so that we can bring people out of those silos, we can unite and finally really start affecting change across the state with David's priority of lowering these numbers. And we'll get more into that later. But the lead organization here is the Family Medicine Education Consortium. What a beautiful way to unite efforts is really bringing the providers of maternal health to the table. So family medicine obstetrics, our obstetrical colleagues, and all of you who have a voice that impacts and translates to some kind of care, some kind of effect on our moms across the state. So the Office of Diversity, Equity, and Inclusion at Penn State Health is represented. The Pennsylvania Department of Health, David's office as director of the Health Office of Health Equity, but also the governor's office. So we're fortunate to have our founding members be from the Commission on Women, but also the Commission on LGBTQ+ affairs. So, you know, the language, we want to make sure as we form this collaborative and as we go forward that our language is truly inclusive, and that we're sensitive to that fact. And also the National Hispanic Medical Association, the Pennsylvania chapter, is also represented. Color and Culture as well, specifically the Latino Connection Foundation. So those are kind of all of us who make up the founding team, and you'll hear from us throughout this afternoon session. So as you know already, maternal mortality is an indicator of our nation's health. And while the rates of that mortality for all racial and ethnic groups in the US has decreased since 2020, we know that disparities persist, especially for Black women. And just 2 years ago, there were almost 50 deaths per 100,000 live births for Black women compared to 19 per 100,000 for white women. and almost 17 per 100,000 for Hispanic women and 13.2 per 100,000 for Asian women. In Pennsylvania, however, the rate rises to 163 per 100,000 women. Live birth. So that's a crisis in Pennsylvania. And this was 2 years ago. The data is not yet available for the most recent data that we have is 2022. But this is why you all are here. And we're excited that there's more than 40 of you here because we have to act, and to do it, we need to do it together. The other thing that was important as we built the foundation of this collaborative was reminding us that the large drivers of this disparity, especially for our Black women, is the social determinants of health, but also racism in medicine. All of the things that impact that individual's health, right? So in clinic, only 20% of what impacts that individual's health has anything to do with the clinician sitting in front of them. And 80% of that has everything to do with all of the things that they experience the minute they step out of our office. So it was important for us to be mindful of that and make sure we're addressing all of these domains: healthcare access and inequity, racial and ethnic disparities, education, health literacy. What are their community services? What are their sources of support? What is their economic stability? And what is their food security or lack thereof? And also, how do all these things intersect to truly impact the health of this individual? And also, how do they deal with the racism that they're encountering every day that we still hear on the news happening in 2024? We know it's real. And what can we do about that to really move the needle forward? So overview of the collaborative priorities. Again, this is a 30,000-foot view. We're going to get much more into detail as the afternoon goes on. But we wanted to engage a diverse group of stakeholders. I will argue that we have accomplished that. I'm so excited by everyone who's here representing. We wanted to also convene, most often virtually, because that's what's going to be most convenient for many, so that we can share information on what are people doing currently to address maternal morbidity, these health disparities and social determinants of health. But how do we collaborate? How do we get out of Penn State Health and collaborate with people in different counties across the state? How do we collaborate in Philly? How do we collaborate in Pittsburgh? How do we work together to lower these numbers? And also, finally, we want to provide education. We want to create partnerships. We want to identify promising models to spread this information to create sustainability across our efforts. And as we're putting forth grants with affect change, we hope that this is going to be a network of expertise, of power for all of you who are trying to do the things, and that we help each other move the needle forward. So we're gonna eventually, I'm gonna just briefly show you Implicit Network. They're here. They're gonna tell us about the amazing work that they're doing, and then also Philly Joy Bank. And then we'll end with a breakout, or we'll do that later. So I'm gonna stop sharing.
Well, first, I want to thank the partners that are aligned on this particular topic. It's a vexing topic. It's a vexing issue. Dr. Ramirez, really appreciate her stepping up to really help us lead this effort. At our last summit, so I'm David Sowens, I'm the director of the Office of Health Equity for Pennsylvania Department of Health. And we have had 3 different summits, in-person hybrid summits. And we were here in Harrisburg. Dr. Ramirez was one of our panelists as it relates to maternal health. And we even, on our first day of the summit at Harrisburg University, between the 2 days, there was a lot of discussion around maternal health. And we heard some horrific stories from our panelists. In some cases, they were physicians or people working in the healthcare field, and they even themselves were treated poorly. Not only have they seen it, but they've seen it. They've actually experienced it. all of the poor outcomes, and it's unacceptable. From my vantage point, every person should have, every birthing person should have a joyful maternal experience, and for many, that's not the case. So, fortunately, we have an all state department focus, or many of our departments within the state are focusing in on this. We have within our department alone, we have the Bureau of Family Health, which is largely focused in on reducing maternal disparities. And I'm going to touch upon that. So we have something within our department called the State Health Improvement Plan, and we have a goal to reduce severe maternal morbidity from 92.4 out of 10,000 in 2020 to 83.2. I said 10,000, actually 100,000, down to 83.2 by the year of 2028. How do we anticipate doing that? Looking at counseling about nutrition, just to name a few, breastfeeding and education, counseling against use of tobacco and alcohol and illicit drugs, increasing the number of community-based doulas. I think we're going to hear a little bit about that going forward. You know, the screening of women with high risk, looking at hypertension, educating women about the early signs of pregnancy. But so we have a state health improvement goal, and we have an entire team that's made up of stakeholders and state departments focused in on that particular goal. Again, some additional things that we're looking at is increasing birthing persons engaged in doula care, reimbursing doulas through Medicaid, increasing the number of certified perinatal doulas. So a lot of work there. But we also have another goal that is not necessarily a maternal focused goal, but it's goal 1.3 under the State Health Improvement Plan, which looks at environmental health, because we know that extreme heat is not going to do much good for birthing people. And we know that many of the most vulnerable populations live in environmental justice communities. So it makes perfect sense for us to even address maternal health through that lens as well. So we're looking at improving environmental health, consequently improving health outcomes for those living in environmental justice areas. So know that there's even that particular goal that can positively impact maternal health. As I mentioned, the Bureau of Family Health, and I know Giselle from BFH within the Department of Health is on the line. And out of their Pennsylvania Title V program, we're talking the current iteration. I know the next iteration, which starts, I believe, in 2026, has even a more expanded goal around maternal health, but the one that we're currently in looks at reducing or improving maternal morbidity, I should say, and mortality, especially where there is inequities. And they have a series of strategies, which pretty much align to what I mentioned a little bit earlier, but I'll drop a few. They want to look at, or they are looking at maternal mortality review committees' recommendations to inform programming, implementing care models that include preconception and interconception care, and a whole host of additional strategies. So the Bureau of Family Health is clearly working in this space. And they are also a part of a maternal health strategic planning team. And we are lucky to have Tensei from my office also a part of this. But we have several departments that are working together, not only DOH, but the Department of Human Services, the Department of Drug and Alcohol Prevention, the Insurance Department, as well as the Governor's Office. So it's at the highest levels of our state government, all working to address this issue. They have 5 priorities, more details to come about these priorities, but looking at access to high quality care, supports for behavioral health and substance abuse disease, addressing the social determinants of health, as Dr. Ramirez mentioned, that being extremely important, looking at rural and maternity care. I know our friends from March of Dimes are on the line. I know they have done reports on that particular topic, as well as increasing workforce diversity. And I'm happy to know that equity is a centering priority for all of that work. So more to come on that, and however the Office of Health Equity can continue to add to this work, we are going to do our best to do so. So thank you all very much.
Hi, everyone. I am Betsy Lorenzo from Latino Connection, a Color in Color catalyst. I also want to say thank you for everyone to joining us today. So we're trying to assemble a diverse multi-sector group. We're pleased with who has been joining us in our initial meeting. So let's see who's joining us today. So we are going to launch a poll. So if you could please choose what group you represent. I believe you will see the poll in a minute or so. Here it is.
So Betsy, do you want to continue?
Yes. So I see we have most of 30% is from healthcare providers, government. So once again, thank you for joining us here today. I'm going to close the poll. And then I guess we have time for more and more questions. Am I correct? Yes. So, okay. So this collaborative is all about getting your input. If you would, or if you could have a magic wand, how would you reduce maternal mortality? I'm going to give a quick example. If I would have a magic wand, all pregnant individuals who use tobacco will magically be connected with tobacco treatment specialists and have a quit plan. So if you could use the chat to write your answer. So early access to prenatal and postpartum care. I also have all people will access the quality care they need and believe and be listed to. Nice. If I had a magic wand, I would want all pregnant women to be connected with social services. Okay, great. Thank you, everyone. So we don't have a magic wand. So let's hear about some real world action. So I'll pass it over to Scott.
Great. Thank you, Betsy. What I'm going to be introducing today are some examples that we want to hear about that are happening in Pennsylvania. But before I do that, I just want to introduce myself. I am Scott Allen. I am the CEO of the Family Medicine Education Consortium. As Dr. Ramirez mentioned, we're excited to be leading and helping to lead this group. We're also thrilled that there are so many healthcare providers on the call. We, as an organization, represent academic family medicine. So there are almost 60 family medicine residency training programs in Pennsylvania, and I know many of them have joined today to hear about what they can do and how they can work with partners in government and social services to address maternal health. But as I think Dr. Ramirez also mentioned at the very beginning of the session, we want to make sure that we are not just kind of strategizing about what we can all do together, but we're learning from all the good work that's happening on the ground right now. We know that many of you are actively engaged in this issue with different projects and programs and partnerships. And so we hope to use these meetings going forward to spotlight some of those programs. We're going to have two speak briefly today, two briefly really, to be able to really get a sense of all the great work they're doing, but just to kind of put these programs on your radar. We're happy to then have other programs be spotlighted in the future and to share information virtually and through whatever kind of email and web presence we end up with for this collaborative. So I'm going to introduce our first maternal health success in action project, which is the one I know well, and it's the Implicit project. Implicit stands for Interventions to Minimize Preterm and Low Birth Weight Infants Using Continuous Quality Improvement Techniques. It's a project that we had a hand in starting at the FMEC But with that, I'm going to turn it over to Dr. Mario DeMarco, who can introduce himself and tell you a little bit about Implicit.
Let me introduce myself. My name is Mario DeMarco. I'm a family physician at the University of Pennsylvania. I'm a family physician that does obstetrics. And so I come to this maternity care issue with a lot of perspective as a provider for family health, for adults, for preventive care, for children's health, for pregnant women in the obstetrical unit, inpatient, outpatient. I work at an FQHC. I've been doing that for 15 years and provide high-risk prenatal and postpartum care in that setting. And I work with a wonderful network of people who trained me to think like a family medicine OB doc, and who helped build this network called Implicit, which allowed us to think more deeply and broadly about the people and the communities and the families that we're serving, really as a systems-based issue and not a series of clinical encounters. And I'm very grateful for a wonderful team that I work with, including Anna Fedoroff, who's our Implicit network manager. And we're all convening in Philadelphia right at this moment for the start of the Family Medicine Education Consortium Conference, which is starting tomorrow. And so I want to talk a little bit about Implicit and what our work does and sort of the potential for this as a network, a series of interventions, and just really a philosophy to address maternal health, and really an answer to both poor maternal health outcomes and infant health outcomes, but also maternal mortality, which is that, a crucial metric which symbolizes so many more ripples besides just the numbers that we see year to year. And so, people wonder, well, what is Implicit? What does it even stand for? It's the interventions to minimize preterm and low birth weight infants using continuous improvement techniques, which is a mouthful. We just call it Implicit, but 20 years ago, we really started a network that was designed to think about how we can intervene with better prenatal care to reduce preterm birth and low birth weight infants and infant mortality. And it turns out that the time to really intervene around that is not during pregnancy, but really every time before that. And so our network, the name has not changed, but the work and the philosophy has shifted somewhat to really think about how we impact maternal health before the time that people become pregnant. And the way to do that oftentimes is after a pregnancy or before people are seeking preconception care, if they are in fact seeking preconception care. As a network, we're really framed around doing quality improvement. We've implemented, built, evaluated, and are now disseminating several models that are generalizable to primary care. We try to improve adherence to sort of evidence-based practices in pregnancy, which we shifted away from. And for the last 10 or 12 years, we've really focused on interconception care, which is, you'll hear a little bit more about, a way to introduce preconception health, maternal health screening at well child visits. And then after ACOG released its statement in 2019 to say that 2018 actually, we need to tear apart and redevelop and redesign a paradigm for postpartum care that is sort of locked into the holistic care for dyads that takes into account mental health and physical well-being and emotional health and family health and lactation and nutrition and sleep and all of the other sort of components that sort of go into thriving postpartum. We had conversations about using the network that we've already built to really address that sort of fourth trimester care model. And, to our knowledge, there's nobody that's sort of deeper into developing a platform and a model to sort of answer that call to action from ACOG 6 years ago. And finally, we can do a lot at a practice level and a provider level, but we need to continue to have conversations that sort of push us forward, address new concerns, identify new knowledge and opportunities and technology, and creating a forum where we can have webinars and meetings and discussions and listserv and sort of have a collaborative. We can all grow, and if we can push those of us who are doing perinatal health to have that support and have a connection to something besides our clinical practices, I think that there's a lot of room for us to improve the care delivery, not just in the clinical setting, but really just in that public health community that we're serving. Implicit is a multi-state collaborative now in 11 states. We're keep on shifting westward across the Mississippi, hopefully, and really trying to, make a more national presence for what we're doing. But really, the cornerstone of the network is Pennsylvania, which is where the Implicit network started and where it has grown and where the majority of our active sites really are. You can see in this map that there's now 16, 17 sites in the Implicit network. They are anchored around some of the larger markets in Pennsylvania, including Pittsburgh, Lancaster, Philadelphia, but really representing a lot of different organizations and clinical settings all over the state. And we're looking to build additional relationships outside of the traditional academic family medicine residency programs that have been the backbone of the Implicit network for a long time, and really think that there's a lot of opportunity for Implicit and its programs to be deployed and established and baked into some of the EHR and workflows in communities with the highest maternal mortality and morbidity in the state, thinking about how we can use what we've learned in areas that have the highest need. I'll talk about the two programs briefly, but I'll start with Implicit ICC, which is our interconception care project. So while this model doesn't reach people that have never been pregnant, it really does take, advantage of a missed opportunity that exists. We do know that once people become pregnant and they go on to deliver, that in that postpartum period, there really is not a lot of care that they receive for themselves. In fact, 40% of people don't attend a postpartum visit, 50% of people don't get any primary care in the 6 months following delivery. We know from Medicaid data that 2/3 of all data that, all dollars that Medicaid spends on a mom-baby dyad in the first year after birth is to pediatric care. So for somebody who went through pregnancy, had a birth, had a hospitalization, and has a baby, almost none of the healthcare resources are devoted towards that, to that birthing parent. And one of the reasons why is because they're prioritizing the care of their infant. And any of us who are parents do the same thing. There's a newborn visit, a weight check, a 1 month, a 2 month, a 4 month, a 6 month, a 9 month, a 1 year visit. There's lots of care in that time period. It's just not care for the birthing parent. And that is a clearly missed opportunity to talk about depression, contraception, preconception health, to address substance use, including tobacco or opioids. And we've established that this is a great opportunity where there's an attentive audience. We know from robust data, and we have a database in REDCap that's housed in Lancaster that has over 200,000 data points from well child visits since the model was put forth, representing about 75,000 parent-infant dyads. And if you look at that data, the birthing parent is present at 94% of those well child visits. They're almost always there, and they're willing to take advice about their own health, even though it's a pediatric appointment. And when you screen for these 4 modifiable risk factors that we've identified in the model, at least one of them is positive 2/3 of the time. And so there's an opportunity for primary pediatric providers and FQHCs and academic sites, whether you're a pediatrician or family doc, a nurse practitioner, to address maternal health because you screen for it. Otherwise, you would not have identified it. And while the American Academy of Pediatrics has pushed recommendations to screen for depression at well child visits up to 6 months, in our model, we do this up to the time that a child is 24 months, and maybe we should be doing it longer. So in this way, we're screening and supporting birthing persons, even though they're coming in for their child's pediatric visit. And in a lot of ways, the care and health of that dyad is probably more, better off addressing maternal health needs than those infant questions about stage 1 baby foods, or is this a serious rash, or does this poop look okay? We're doing vaccines and other important work at those pediatric visits, but really there's an opportunity to expand some of that to higher needs for a family dyad, especially those that have high risk, including substance use or violence or other concerns that may be risk factors for poor maternal health outcomes. And so we are looking at behavioral change in this model, seeing if intervening, when we identify one of those risk factors results in a behavior change, whether counseling or offering nicotine replacement can address maternal nicotine use or tobacco use, whether prescribing or providing multivitamins reduces the likelihood that somebody is not taking multivitamins and increases the likelihood that they actually are using multivitamins with folic acid at the time of their next pregnancy, and so on and so forth. And so our data set, our research team, and part of the implicit network is really sort of dedicated towards looking at this. And we can look at this not as a research question, but really as a process improvement and clinical care and quality assurance improvement in communities all across the state. I'll shift to the implicit network's response to the growing maternity care crisis, which really wants to utilize this network primarily of family medicine types of practices that are doing prenatal or obstetrical care, and also seeing families in the aftermath to approach a care model that was very different than the singular 6-week postpartum visit that wasn't patient-centered, in fact, so unpatient-centered that most people didn't attend it. And by that time, a lot of the complications that might have been present, including signs and symptoms of preeclampsia or cardiomyopathy, might have been present. Struggles that people are having with breastfeeding or lactation or nutrition or sleep or pain, they've either sort of given up or moved past that. It's really about a model that's sort of more patient-centered and addressing the need earlier when it's more necessary, and providing postpartum care that is more longitudinal and earlier than previous models. And so, in creating this model, we really ask practices to sort of establish, from a population health perspective, who are your people, whether you deliver them or they deliver elsewhere. You should be following them up afterwards and connecting them to all the right care services. And so you need to know who that registry is, particularly those that are at highest risk. We want to provide postpartum care in the ACOG recommendation within 3 weeks of pregnancy, of childbirth, and sometimes within 1 week, depending on what's happened, and integrating people with monitoring, lactation, support, and home visiting, as those exist in the communities where you're serving. And then we want to make sure that we're enhancing the care delivery by not only screening for things like substance use, intimate partner violence, mood disorders, or chronic conditions after pregnancy, but also providing a mechanism to connect people to the right resources once we've detected those. In our care model, we really start thinking about postpartum care in pregnancy, in that 3rd trimester, and being prepared to address the challenges. Because a lot of conditions that exist that are the drivers of poor maternal health outcomes in Pennsylvania and in the US, things like mood disorders, mental health conditions, substance use, intimate partner violence, chronic conditions like high blood pressure or diabetes. These are things that are not surprises in postpartum care. These are things that we knew about already, and we can make a difference at a time when people may need access to those care services. So having those resources and having a plan can be critically important. We want to layer on some of the risks that happen at the time of birth, including trauma and traumatic birth, poor birth outcomes, infants going to the intensive care nursery, which is an independent risk factor for postpartum depression, things like that, and be able to communicate those risks to the outpatient team. And we want those patients to be seen by their team that know them within 3 weeks of delivery. And we want to make sure that as they're wrapping up from their pregnancy care, that we're making a transition from maternity care back to primary care so that people can get these needs addressed, whether they're related to substance use, mood disorders, or chronic illness. Just want to highlight that this is a network because we're working with so many organizations that's learned how to form relationships. I'm very grateful for the March of Dimes, a woman named Dolores Smith, who connected us to the Pennsylvania Department of Health many years ago, currently for the Eastern and Western March of Dimes organizations, for our Pennsylvania Department of Health, which has funded the implicit network over the last 8 years from the Bureau of Family Health, and for those project officers who have been exceedingly supportive of the work that we're doing. We are connected to some of the largest birthing hospitals in some of the largest cities facilities in Pennsylvania, including McGee, University of Pennsylvania, Lancaster, and trying to make relationships with other hospitals too in areas where there may not be have not previously been engaged. And we welcome and celebrate sort of partnerships with community-based organizations that we sort of bring in to support some of the teaching and the workforce development that we're doing. And just to the right is an example of the toolkit that we originally wrote in 2015 and then rewrote in 2024. Was it this year? With the support of the March of Dimes, which we allowed to be freely downloaded from the March of Dimes website, so that sites that are not part of the implicit toolkit can download this and sort of be able to implement this model as a do-it-yourself kind of a way. Although we really do encourage everybody to reach out and be a part of the implicit network if you're looking to integrate these types of programs in your health system. So with that, I'll stop, and I think that there'll be some time later for questions, but I just want to say thank you for the opportunity to be here today.
Thank you so much, Dr. DeMarco. And yes, we are going to try and squeeze in a few questions for Dr. DeMarco about implicit after our next short presentation. And in the meantime, if you do have questions, please feel free to go ahead and use the chat so that we can make sure to answer them. I'm going to move quickly to our next example. I think we're going to hear from a very different type of program from Nia Coxum, who runs the Philly Joy Bank. So Nia, if you want to take over, that would be great.
Confirming you guys can see the full screen view of my slides.
Yes.
All right, great. Hi, everyone. I'm Nia Coxum. I'm the Philly Joy Bank Program Manager with the Division of Maternal Child Family Health with Philadelphia's Department of Public Health. I am also a birth and postpartum doula, so I come to this work through many lenses. So first, just to talk about our why and why the Philly Joy Bank even exists. First, to start defining the problem, Philadelphia is the poorest of the 10 largest cities in the US. This graph on the left shows that 21.7% of residents are living in poverty in Philadelphia. Philly also has the second highest infant mortality rate, which is defined as the death of a baby before their first birthday for every 1,000 live births. The most common causes of infant mortality are prematurity and low birth weight disorders. And this graph on the right shows that infant mortality doesn't affect all Philadelphians equally. This orange line here represents the infant mortality rate over time for Black infants. And while it's decreasing, it's still too high, but Black infants in our city are 2 times more likely to die before their first birthday than white infants. And this, I'm sure, will come to no surprise to, most of us. But these disparities mirror the same disparities in poverty, specifically in Philadelphia, things such as disproportionate exposure to stress, financial stress, community violence, and then implicit and explicit racism that's often encountered in our healthcare system. So once again, just to hone in on that point, it is racism, not race. Dr. Monica McLemore says there is nothing inherent about Black skin that increases risk during pregnancy, except perhaps overexposure to the real culprit, racism, which can harm a mother's body in real measurable ways. So the idea for the Philly Joy Bank came from our Philadelphia Community Action Network, also known as the Philly CAN, which is our multi-sector collective impact group that has the goal of eliminating racial disparities in infant mortality in Philadelphia. Our stakeholders include health systems, providers, community-based organizations, maternal child health advocates, and most importantly, our lived experience experts who are pregnant and parenting people of color who really help to develop and drive the direction of the CAN, and specifically the Philly Joy Bank as co-chairs and as members of the different work groups. So 2 years ago, the CAN went under a strategic planning process to revamp our approach. We held a series of community stakeholder meetings to review the perinatal periods of risk, quantitative and qualitative data to identify areas where we could really have the most impact, and we prioritized 3 areas for action. I'm going to highlight the holistic mental health work group, and data that came out of that PPOR analysis shows that birthing people who gave birth in Philadelphia between 2018 and 2020 reported these stressors as the top 4. So traumatic, relationship, financial, emotional. And out of these 4 stressors, financial stress was reported as the top amongst all racial and ethnic groups. So once we honed in on financial stress, we conducted a literature review to see how others were addressing financial stress in pregnancy, which led to guaranteed income as the solution. So for those who may not be familiar, guaranteed income is similar to universal basic income. Sometimes they're used interchangeably, but they are slightly different. So guaranteed income is a cash payment provided on a regular basis to members of a specific community with no strings attached and no work requirements, compared to universal basic income, that's unconditional cash stipends for all citizens regardless of need. So guaranteed income has proven to be successful in improving birth outcomes in other areas. So the Healthy Baby Prenatal Benefit occurred in Manitoba, Canada, where low-income pregnant people received unconditional cash transfers during their 2nd and 3rd trimester of pregnancies. This, increase in income led to a decrease in preterm birth by 17.5%, a decrease in low birth weight by 21%, and an increase in breastfeeding by 4%. And then participants reported using the extra money to improve their nutrition, prepare for the baby, engage in self-care, and really just, moderate the effect of stressful life events. Another example of guaranteed income in child development is baby's first years, where 1,000 low-income mother-infant dyads either receive $333 a month or $20 a month for the first 52 months of their child's lives. And the moms who received the larger cash payment were more likely to spend time in early learning activities and spend money on child-specific goods. So now that I've given you guys a little background into, why we're doing the Philly Joy Bank, where it came from, some evidence on other guaranteed incomes, I will share with you about the Philly Joy Bank itself. So this is our innovative way to address birth outcomes that is evidence-based. And we chose the name very intentionally because we really wanted to emphasize joy as a key part of pregnancy and parenting, and highlight the significant financial resources that are needed to sustain and support a thriving family. So we are currently enrolling 250 pregnant people in Philadelphia to receive $1,000 a month for 18 months, beginning in their 2nd trimester of pregnancy. And in addition to this monthly income, our participants are also being offered additional voluntary support, such as financial support. So they're receiving financial coaching, benefits counseling, and then perinatal supports, such as dual support, breastfeeding, lactation, home visiting support, and safe sleep education. In terms of eligibility for the program, applicants need to be at least 18 years or older. They have to be pregnant in their 2nd trimester, specifically between 12 and 24 weeks. And then they currently have to reside in one of 3 neighborhoods in Philadelphia: Cobbs Creek, Strawberry Mansion, or Nicetown, Tioga. And then they have to have a household income of less than $100,000 per year. And we chose these 3 neighborhoods because they have the highest percentages of very low birth weight, which we're using as a proxy for infant prematurity. They also are disproportionately poor, as you can see, the median household incomes here on the slide, and they also are the neighborhoods that have very high percentages of Black births in the city. So from the CAN, we formed a steering committee specifically for the Philly Joy Bank, which has multi-sector representation that you can see here, once again, with our lived experience experts at the core. So our lived experience experts, this truly is a community co-developed, co-led program. And our lived experience experts have provided input on everything from program planning to implementation, from the smallest decision to the larger decisions that were included. So one thing we're also very proud about is avoiding the benefits cliff. So the benefits cliff is the sudden and often unexpected decrease in public benefits that can often happen once someone receives a small increase in earnings. So in order to avoid that benefits cliff, we were able to receive waivers from the state for Medicaid, WIC, SNAP, and LIHEAP. So folks who are receiving those public benefits will not lose those benefits because they are receiving this additional income. In terms of outreach and recruitment, we've been very intentional with conducting targeted outreach at places where pregnant people frequent. So prenatal care providers, WIC offices, child care facilities, home visiting programs, and then other health and community settings, especially in our 3 target neighborhoods, and really building connections and tapping into existing community organizations that are already trusted among our target community. We also held a very large baby shower and launch event back in June. And then from a media standpoint, we've had press releases, we've done some media interviews, and have also disseminated social media posts and then flyers to hand out in our target neighborhoods. So applications opened on June 24th, and as of this week, 112 participants have been selected, and we will continue to conduct random lotteries every 2 weeks until we are fully enrolled with 250 participants. So what will success look like? How are we evaluating this? We have partnered with researchers from Drexel University's Dornsife School of Public Health. Our research aims are to assess the feasibility and acceptability of this program, examine whether and how guaranteed income affects parental time and bandwidth, ability to meet basic needs, parental stress, and then explore the preliminary impact of the Philly Joy Bank on maternal and child health outcomes. So once again, these are initial outcomes in the middle here in blue that we are looking at: improved engagement in healthcare, decreased parental and postpartum stress, improved ability to address basic needs, and then a more supportive postnatal environment. And how we are accomplishing this. So we're doing a mixed methods approach. We have our Cash Plus Care group. These are the folks who are selected to actually receive the $1,000 a month. And then we have our Care Only group, who are folks who unfortunately weren't selected to receive the money, but they're still being offered those voluntary supports. And we're doing this through surveys, looking at birth records, and then asking participants to share their own experiences. And then from a policy standpoint, obviously 250 participants is not a lot of people. So next I'll just share a little bit about how we're looking at sustainability from a policy standpoint. So one of our goals is to make existing cash transfer programs more guaranteed income-like. So expanding the state earned income tax credit, bringing back the expanded child tax credit, and then making changes to TANF. We also would like to be able to leverage existing maternal and child health funding. So allowing these federal dollars that are supposed to be used for maternal and child health initiatives to be able to be used for disbursements. And these are our wonderful funders who we would not be able to be implementing the Philly Joy Bank without. And that is all.
Thank you so much. It was so interesting to hear about the Philly Joy Bank as well as the Implicit Project. I know we had hoped to take a few questions, but I think we're going to keep moving on through the presentation. I would love for people to continue to use the chat to put your questions in there, and then we will follow up after the meeting with slides and answers to all those questions. But we want to make sure to get to our breakout groups, which is where you'll have the opportunity to give us input. So thank you again to our 2 presenters. And if you have ideas for who you'd like to hear, projects you'd like to share information on in the future, please go ahead and send a chat or send me an email. With that, I'm going to turn it over to Sean at Latino Connection to go move into our next segment.
All right. Thank you, Scott. And thank you for those wonderful presentations, Dr. DeMarco and Nia. Those programs look awesome. I wish we had a magic wand that could just expand both of those programs. So yeah, my name is Sean McCormick. I use the he, him pronouns. I'm a public health professional, and I'm the Associate Director of Public Health Programs at Latino Connection and Color and Culture. And if you're not familiar with us, we are basically a public health and outreach agency. So we do some marketing and media and communications, and then we do a bunch of community-based healthcare and prevention type programs. So we sort of sit in between where healthcare and public health intersect. So a coalition like this or a collaborative like this is a perfect place for us to be involved. So thanks for including us. So as we met before this, kickoff meeting, one of the conversations we had was about whether or not we should be surveying Pennsylvanians about the barriers to maternal health. And one of the things that came up was, well, there's already been a lot of good research about the different barriers to maternal health. So rather than spend time on assessing those barriers, let's list them, try to prioritize, and move this group into a place where we're creating action, have measurable goals, and we're accomplishing things and creating real results as quickly as possible. And so we're going to talk more about exactly what that looks like in these breakout groups, and we'll have some goals set up by the end of this very first meeting. So just to kind of set the stage for the breakout groups, through some research, I think a lot of folks here are probably aware of these things in terms of what are the major impediments to maternal health and what are the drivers of maternal health and childbearing related health disparities. And a few of those, just to mention them, include things like lack of transportation, lack of leave or lack of childcare, people are too busy, lack or no health insurance coverage, emotional health barriers, racism and healthcare related discrimination were both mentioned, lack of digital health literacy and broadband access. So, right, those are some of the barriers. And then we know there are some solutions. We heard about some of the solutions just a second ago. So, right, how do we expand healthcare? Is it through telehealth, expanding insurance coverage? Is it mobile clinics? Say we want to focus on patient education. What about provider education? Should we focus our efforts on that side of it? Maybe there needs to be more work done on legal resources and social services and ensuring that patients and individuals and families aren't denied benefits or aren't evicted from their housing or have legal representation during intimate partner violence or divorce proceedings. So we're going to do another quick poll, and it's not going to be a completely comprehensive list, but it will have some of the solutions or like categories of solutions that we'd like everybody to rank. So please pick what you see as the single highest priority in terms of reducing maternal health disparities. So nobody prioritized telehealth as the top one. Provider training and training requirements received, so there's three that are tied at 32%. Provider training and training requirements, doulas or community health workers, and patient resources. And then legal resources did receive, it looks like 1 or 2 votes at 5%. Thanks, everybody. And I believe
and do you want to move us into the breakouts?
Yes, absolutely. Hello, everyone. My name is Tensei Getz. I'm the Healthcare Opportunity Initiative Coordinator for the Office of Health Equity. I'm sure I've met some of you. We're going to be splitting you guys into randomly to 5 to 8 groups into breakout rooms. And we're just going to encourage everyone to think about all stages where we could have impact, whether it is during pregnancy, during labor and delivery, post-delivery, and in between pregnancies. So there's going to be 4 questions for the breakout rooms. The questions are, what are some of the resources that are created but underutilized? What needs to be created? What is happening now that we can build on? What is the one goal we can accomplish by the end of 2025? And what is the systemic and toolars to address immediately, but should be our ultimate goal? So please try to move through each question. If you don't have time, that's fine. And during the breakout room, please identify a note taker who will be asked to briefly report out after the breakouts and as time allows us. And also feel free to record notes and put them in the chat after we reconvene. Some of our colleagues, Emily and Sam, are also here to help out with note taking if they are in your breakout rooms.
As far as report backs, I know that some groups might not have had the chance to find someone to report back, but for what I'll kind of model for my group is I'll say what sort of what I heard, or I think, who was it that was taking notes in there?
I took some notes.
Oh yeah, Sean. So if you want to say what you had in notes, that would be great.
Yeah, sure. Thanks, Ashley. Yeah, so yeah, we only got to a couple. One of the things that we could build on that somebody brought up is that there are existing trainings for implicit bias. That would be something that, since those and other topics relate to patient safety and trainings for mental health providers, existing trainings could be made more available, basically, as an action that we could take. And then a level up above that is to work to make certain trainings required as part of licensure and continuing education credits. Sarah, do you want to just talk about the dashboard idea? You got cut off there at the end. That was your idea, though, so I'll let you report on that, if that's okay.
Talking so fast, like, oh my God, 1 second. So yeah, no, I was talking about a dashboard. Like, wouldn't it be great if we can create a dashboard where we can see in front of us the data? So the data is the driver for all the things, right? If we're talking about funding, moving the needle forward, etc., we need the data. So when we're looking at the 5 domains of the social determinants of health and how they intersect, what are the top drivers in Pennsylvania that are driving the mortality rates for our Black birthing individuals? And I feel like if we knew that, how great that would be, because then we can really prioritize our efforts as we march forward. And so for me, I thought about, understanding the landscape. A goal for 2025 is figuring out who has the data. If we're not collecting the data, how do we collect the data? And how do we create a dashboard for our collaborative that we see that data? And if you remember, like during the COVID pandemic, you clicked on the CDC link and it was like live, like what's happening. That would be the dream. But until then, it's, where do we begin with all of this? But in order to know where do we begin, we need to know what is the highest driver.
And I think using examples from COVID is a really good example of sort of how we saw things change really quickly, and we can watch them change again for the better. Is anyone in group 2 ready to report back?
If I could, Ashley, I'm sorry, real quick. I know I've already been speaking a fair amount. Just one thing that I was going to add on to what we might be able to build on is at Latino Connection, we have successfully worked our way into the world of building partnerships and contracts with managed care organizations and insurance companies to pay for maternal and all sorts of health home visits, community health worker-led home visits, which could tick a lot of these boxes in terms of doing a risk and needs assessment, patient education, ensuring access to care. And, if there's a way to fund that sort of effort from that through those partnerships, that could potentially be a fruitful area for expansion. Thanks.
Thanks, Sean. Someone from group 2?
Is that us? I believe that's us. So I'll just use, I guess, the heading of empowerment. Empowering the residents, the birthing people. So Chastity, an RN from New York City, she didn't get a chance to delve into it, but looking at empowering the residents of York. Giselle from our Bureau of Family Health is looking at working through the maternal health work group that I mentioned a little earlier, the interdepartmental work group, and surveying the community to find out exactly what the needs and the concerns are before undertaking an initiative. So basically empowering them to provide us some insight. And last but not least, we have a couple. Molly, who works for the Office of the Attorney General, has already developed a brochure called Know Your Rights. And it speaks to the importance of birthing people knowing their rights in the medical space, specifically as it relates to maternal health. And you heard about the Philly Joy Bank earlier, and basically empowering 250 women, and we can definitely expand that beyond Philadelphia to, utilize those funds to do what's best for them and their families.
Thanks, David. Anyone else in group 2? Is there anything that that you might have missed? All right. If there is anything, feel free to utilize the chat. Let's move to group 3.
From our group, I think Dr. Livingston is here. She's gonna be talking a little bit shortly here.
Yeah, we had a great discussion. As brief as it was really good and intense. We talked about like what's being underutilized and what can we tap into. And so we were obviously talking about like community health workers and doulas. I'm a doctor who loves doulas. Daria Coffey knows that. I think she sits on top of the world. But I do think, as our group kind of alluded, I mean, there's no like doula juice out there, right? It's not like we have to put it all on doulas. And I loved what David said. David said, what is it that we can do to kind of help amplify that touch point in the community? And he had such a great idea. I wrote it down here. That first postpartum visit, healthcare providers would go and visit the patient in their home, as opposed to having them wrap up the baby and put the baby in the car seat and drag them in the car. And, why don't we meet people where they're at, meet humans where they're at? I love that idea, the first postpartum visit in the home. It was his idea. And so we kind of expanded on that. Just to say, how is it that we can meet people where they're at and remain connected with the community? I love the idea because I insert myself in the community every day as a physician so that I know what's going on. I have the temperature of what's going on in the community. What better way than to physically insert ourselves? So that was the highlight of our conversation. I think, Sarah, you made a comment, Sarah Ramirez, you made a comment that I wanted to touch point on when you said, creating this dashboard and seeing the data in front of us. I'm a department chair here at UPMC Lidditz, so I comb through data more than any of us breathe air. And what's frustrating is we can't get hospitals to share patient charts. Like if I have a patient who was not supposed to deliver with me and now they were visiting Target next to my hospital and now they're birthing, it's like I'm pulling teeth to get hospitals to talk and communicate with basic patient information. So I love the idea, Sarah, but I think we need to challenge these systems and organizations to say, you know what, moms are dying everywhere, and it's all of our problems and it's all of our solutions to create. So we should have this interfacing. And it shouldn't be hard or difficult or impossible for us to communicate. So I love the idea. I think we have to ask the hospitals to do something even more obvious, which is share clinical information.
And I think it's important to remember that things that are obvious to us aren't always obvious to many of the hospitals and places that we work for. And so, bringing this information up as part of that good education. We've only got about 5 more minutes, so I want to make sure we get through the other groups. Group, let's see, 4.
I think we were group 4. Is that?
Take it.
Okay. Hi, everybody. I am Daria Coffey, and we were able to have a pretty steady conversation on well child visits. It seems like that was the standout topic. I took a few notes. We all felt that well child visits should be built upon. And what was brought up, that follow-up care, next steps after the social determinant of health screenings should be taken into further consideration. And so we kind of had some comments around what happens after the screening. Are the screenings effective? We see the data from Implicit earlier in this call. People are showing up at their first well child visit. And so there could be a missed opportunity there from physicians to be able to engage families in gathering that information and finding out where they need additional support. And so that was one area. But then we also discussed the matter that some families may not feel safe in responding to these screenings. They may fear consequence, especially families who are historically placed in the margin. And so it was recommended that pediatricians provide safe space, and this could be an opportunity where training and more education for physicians could be better put to use to make sure that our providers are more relational and that they can focus on providing a safe space for our patients. I think that really summarizes what we were able to cover and talk about. We were pretty passionate despite the little interruptions, but I just would close in saying that the safe space is probably one of the biggest things that we could focus on when it comes to well child visits. I'm working on a research paper with University of Pittsburgh, and we're looking at this specific data. What's happening with the well child visits? Are people showing up? Well, now we know they are, but what's happening after that? And so this was our heart work for our group chat.
Thanks. That was a
Awesome.
great summary. Really appreciate it from
Thanks,
our group.
Marlene.
Thanks. And if there's anything else from Group 4 that Juria might have missed, feel free to drop it in the chat. But that was awesome. Group 5.
Yeah, I will do the report out for us, Emily Lebo with the Office of Health Equity. About 2 or 3 big things stood out from our great but brief conversation. One of those being, while family medicine training is very, very vital and important, it was brought up by Dr. Prill that obstetrics should be covered. That is part of the family unit, even if the individual doesn't see themselves delivering babies in the future, that should still be part of their residency program and training. She also brought up that we overall can continue to build upon doing a better job taking care of the family unit as a whole, ensuring that parents have the resources they need to not only take care of their children, but themselves and that family unit. And then Dr. DeMarco brought up the idea that there's so many great community-based organizations doing work around health equity and providing a variety of different resources that sometimes it can be confusing with all these things going on who qualifies for what services, what programs, where, depending upon where you live, your income level. There's so many things that go into it that we can continue to build upon doing a better job connecting providers with these community-based organizations so that that understanding and trust continues to be fostered, just like building trust with patients. It should be a similar bi-directional focus between these organizations and providers themselves.
Awesome. Thanks, Emily. That's really important to remember. Group 6.
I'll go. This is Laura Line. We didn't get very far, to be honest. So Shannon, I hope you'll jump in as well, because as I'm hearing what everyone's saying, it's really helpful. And one thing that I wanted to highlight was just this idea of screening without judgment for the mom in prenatal care early, and just really getting to that issue of stigma and finding, I think the point about screening and well child visit is well taken. And I just wanted to extend that to prenatal care, where screening sometimes seems like something you just get through. So maybe training on screening scripts for how to handle when someone says that they're misusing substances or has a mental health condition. How do you handle that? What is your pathway to support that mom to feel not judged and to sort of really open up the trust at that key moment? So
yeah. And like Laura said, you all discussed a lot in your 15 seconds. We only came back to our group we started with 4 and came back with 2. But one of the things that Laura and I talked about was this group in particular, and the questions that were asked, we found were really broad and large in scope. And we talked about how it would be nice to better understand the folks who are attending this collaborative and just learn more about what each of us do. And I think related to Dr. Ramirez's comment earlier about understanding and detailing the drivers of poor outcomes, also the reverse of that, like actually coming up with a scan of some of the best and promising practices and projects and policy work that's happening across the state so that we can then prioritize efforts and better align those efforts to, you know, capitalize on what everyone's doing.
Great. Thank you all so much for your input. Sorry again for the technical difficulties, but I think we just had a great discussion, and thanks to Ashley for leading that. I'm going to turn it over to Dr. Ramirez one more time to wrap us up.
Man, such great conversations happening in the chat. I love that everyone is so fired up about this topic. I think that as we are having these conversations and these meetings, there are going to be people that you're like, hey, they should be at this table too. We need them there. So please feel free, like I put in the chat, I challenge you to go back to your health systems, figure out who's a change maker, and they should be at this meeting, this conversation, because as Dr. Livingston said, we're not going to affect change if the right people aren't at the table. So I'm excited about the passion, the interest for everyone here, everything you've shared with us. Keep an eye on your emails, and please send us questions, comments, concerns, even after the meeting, if your brain's like going and going and going, and you want to have a conversation or generate a document. At some point, Scott will perhaps create a shared drive for the entire collaborative where it could be a dumping site for all the things and an easy access for all of you as well, including today's PowerPoints. Scott, anything else?
Nope, that's great. We will do just what Sarah said. We will put together some materials after this so you can see them again and share them with others, and we will be in touch about future meetings.